Good morning, dear colleagues and friends. It is a pleasure to be here today. My name is Professor Nathan Bornstein. I'm from Tel Aviv, and I'm presenting this interesting case on behalf of my colleagues from Romania, Professor Dafin Mureșanu and Professor Adina Stan from Cluj-Napoca, Romania. Let's start the show. We are talking about a 43-year-old female who was admitted to the hospital on May 2019 with the following symptoms: somnolence, forced ocular deviation on the right, to the right, left hemiplegia, the NIHSS was 15, and all the symptoms actually occur upon awakening. In her past medical history, she had 2 episodes of DVT, deep vein thrombosis, one on the right leg and the other one on the left leg at age 21 and 37. No pregnancy. Because of the DVT, she was put on vitamin K antagonist treatment. Now, the course of the current disease is as follows. In 5th January 2019, she had an episode of visual loss of the right eye, lasted for 2 days and resolved. 3 weeks later, she had another focal neurological episodes consisted of left hemianopia and mild left hemiparesis. At that time, she had an MRI, and as you can see on the left-hand side is the DWI, diffusion-weighted imaging. As you can see, there is a spot on the left side with DWI positive, which means ischemic event. You can also see that on FLAIR, there is a hyperintense lesion on T2, and there was no enhancement on T1 with contrast. So in this case, after 2 focal neurological episodes, what do you think? What is the potential diagnosis? Of course, in a young lady like that, you want to exclude demyelinating disease. So a blood test, routine blood test was performed and was negative, and lumbar puncture, LP was performed, which revealed 20 white blood cell counts. At that time, the oligoclonal bands were negative. She went under screening for infectious diseases, and as you can see, all the panel was negative. But because of the clinical picture, it was decided to give her a pulse therapy of corticosteroids, and all the symptoms were resolved and she fully recovered. However, the story does not end here. The story continues. In March 2019, she had another episode. Only 3 months after the second one, with right body paresthesia, and at that time you can visualize the MRI, very impressive MRI, as you can see in the FLAIR imaging. There are further episodes that occurred, and with the DWI multiple lesions were seen with DWI positive, and as you can see also here, also in the posterior fossa. So now we're dealing with multiple positive DWI restrictions, which is more likely to be maybe ischemic, but still we don't know. So what are the etiologies that could be and could explain this aggressive course of the disease? So of course, there are several potential etiologies like multiple sclerosis, cardioembolic stroke, inflammatory vasculopathies secondary to connective tissue disease, thrombophilia, and infectious diseases. There are, for each one of them, as you can see on the table, there are pros and cons, but in any case, it was decided to continue the workup, and a routine blood test again was done, and again was normal. An extensive cardiological examination and investigation was performed, including TEE, transesophageal echocardiography, all were normal. Screening for vasculitis, systemic vasculitis, was negative, as you can see. However, for thrombophilia, it was found that she has an MTHFR A1298C homozygous mutation with mild hyperhomocystinemia. At that time, because of this positive thrombophilic results, she was switched from VKA, vitamin K antagonist, to apixaban 5 milligram twice daily. Additionally, she was put on vitamin B6, B12, and folic acid. However, story continues. In between March and May, she suffered from headaches and she experienced behavioral disturbances. And May 19, she hospitalized because of an event with somnolence, forced ocular deviation to the right, left hemiplegia, the NHSS 15, and it was diagnosed as a stroke. You can appreciate that DWI positive, the whole middle cerebral artery, the left middle cerebral artery, the right middle cerebral artery was affected, and the MRA also showed a right MCA occlusion. So, having said all that, with the fact that she has this MTHFR homozygous mutation and hyperhomocystinemia, the question is whether this may explain the recurrent episodes of focal neurological deficit and the last episode with severe right MCA stroke. What do we know about this mutation, which is much less common than the known MTHFR C677T, the MTHFR A19 and 1298C polymorphism, reduces the MTHFR enzyme activity, and the homocysteine may increase the risk of stroke through multiple mechanisms: thrombosis, impaired thrombolysis, increased production of hydrogen peroxide, endothelial dysfunction, and increased oxidation of LDL-C. So we have a mutation that may increase a little bit the homocysteine, and the homocysteine by itself may cause thrombogenic phenomena. In a cohort and case control study, all have consistently demonstrated a roughly twofold greater risk of stroke associated with hyperhomocysteinemia. In adults with recent ischemic stroke or TIA, who are known to have mild to moderate hyperhomocysteinemia, supplementation with folic acid, vitamins 6 and 12 safely reduce level of homocysteine, but has not been shown to prevent stroke. This is the guidelines for prevention of stroke in patients with TIA in 2004. So is thrombophilia the cause of the disease? Maybe. She had 2 episodes of deep vein thrombosis, no pregnancy. So definitely she has sort of a thrombophilia basis. But no PFO or other intra or extracranial right to left shunt, so the DVT cannot explain the paradoxical embolism to the brain. And the fact she was already on NOAC, on apixaban 5 milligram twice daily, that was supposed to protect her for embolic stroke. However, we know that the reduction of the risk reduction with the NOAC is about 2/3, so she is not fully protected. But on the other hand, this sort of thrombophilia with this aggressive clinical course of multiple stroke in 5 months is very unusual. So still, we were intrigued by this clinical course and the fact that she had this major event, stroke event, on apixaban. We continued the workup, and she went under oncological screening, another panel of infectious diseases, another extended panel for vasculitis, genetic workup for Fabry, all were negative. So what is it? What was the cause of this aggressive course of brain events? Look at this. Finally, she had a search for venereal diseases, and the VDRL was very strongly positive, and repeated LPs showed white blood cell count of 25 and positive, strong positive VDRL. So what is the diagnosis? We thought that she might have had neurosyphilis. The treponema that causes syphilis invades the nervous system within days after the primary infection, and subsequently, we categorize the symptomatic neurosyphilis into 2 categories. One is early, which occurs within 1 or 2 years after the primary infection, and this other one is. I suggest and recommend to you to read this excellent review by Roper in the New England Journal of Medicine 2019. And these are the clinical features of the neurosyphilis. As you can see, the early with asymptomatic early neurosyphilis and syphilitic meningitis with positive VDRL and CSF, and also the fluorescein troponin antibodies absorption. This is the FTA-ABS positive. There is also in between the early and the late stages, you have also in between intermediate, early or late, which causes meningovascular syphilis, including stroke, cranial nerve pulses, and meningomyelitis with progressive myelopathy, including sphincter dysfunction. And all this in lab tests, there's reactive serum CSF VDRL test positive. So we are talking probably about late or early meningosyphilis. This is a very nice graph that shows the meningovascular syphilis is usually interposed temporally between early and late forms of neurosyphilis, typically occur 1 to 10 years after the primary infection, as you can see here on the screen, in between the early and the late stages of neurosyphilis. As for the mechanism by which this neurosyphilis affect the vessels, the pathology of meningovascular syphilis is endarteritis with perivascular inflammation, like the Hubner arteritis in the medium-sized vessels and Nissl Alzheimer arteritis in small intracranial vessels. This causes fibroblastic proliferation of the intima, thinning of the media, and fibrous and inflammatory changes in the adventitia with lymphocytic and plasma cell infiltration. Sometimes, rarely, aneurysmal dilation may occur. As for treatment, as you can see here, the 2014 European guidelines on the management of syphilis, as we all know, sent neurosyphilis, and for the ocular and auricular syphilis, the first-line therapy is penicillin with 18 to 24 million units IV daily, as 3 to 4 million units every 4 hours during the first 10 to 14 days. Of course, in this case, because of the stroke, antiplatelet should be added to the main treatment. So as for the clinical course and follow-up, what happened to this lady? She had no further headaches, and all the behavioral disturbances she experienced actually disappeared. She had no further strokes. However, only mild improvement of her severe neurological deficits occurred in spite of a very intensive rehabilitation program. So I hope that you have enjoyed this unusual case. I hope that you have learned that in young patients with unexplained etiology and reason for their stroke, we should take in consideration syphilis or neurosyphilis as a potential cause of strokes, although rare, but still may occur. Please be aware of it, and I hope that this case actually proves that we should take this in consideration. Thank you very much for your attention.